Hello everyone, I'm Philippa Ryan. I'm a Senior Research Fellow in the Centre for Assuring Autonomy. I worked alongside Zoe on the RTAS project. My background is very much, I'm a safety engineer and a computer scientist. Zoe is a philosopher. It was a very interdisciplinary project, and this talk is about the work we did on responsible and safe use of AI or machine learning, particularly looking at it for a healthcare system. My focus is mostly on what I would call role responsibility and how this impacts on the safety and the way we deploy the AI. Okay, so the first thing really that needs to be talked about is what on earth we mean by responsible use of AI, because it's quite a broad term. We want to know what it means, why it matters, what could go wrong. As I say, we're particularly concentrating on the use of AI for safety critical systems. There are sort of wider issues about societal issues, but our focus was on safety critical systems. And we built a modelling language based around sort of philosophical models of responsibility. And I'm going to show you how we use this for a type 2 diabetes comorbidity decision support system that should be used by clinicians in their consultations, and obviously do some conclusions and some discussion points. Okay. So what do I mean by responsible use of AI? I think if I ask the people in this room, they will probably all have very different interpretations about what on earth I mean by responsibility. So I can act in a responsible manner. I can take the responsibility on for doing something, a certain task. I might be held responsible or accountable for something that I have done in the past. Particularly important from my point of view is what I will call due diligence. So if I'm building a system, I need to build that in a responsible way. I need to consider how it might go wrong and what I can do to reduce the risk involved in building the system. And then there's sort of responsible ways in which we can use this in practice. And there's a work, I think you mentioned the paper about accountability, what on earth we mean by accountability and responsibility. So I can be responsible for something, but I can also be held to account for an outcome from that system. And it's particularly hard with AI and machine learning to understand responsibility. What was responsible, what went wrong, because AI is an imprecise technology and sometimes it will just go wrong. Sometimes it might go wrong because it was poorly implemented. It might go wrong because somebody had oversight that didn't necessarily take that oversight. So one of the things we're trying to do is build these models so we can more precisely pin down the who, the what, the why after something goes wrong. Okay. So we have these different interpretations, and this is largely inspired by work in philosophy. We have our roles, our role responsibilities. So these are the things that we need to do, particularly safety engineering roles or other responsible actors, clinicians and so on. So we have duties and requirements on us, and that is our role. We talk a lot about moral responsibility. This is not to do with your personal morals, I can assure you of that. This is very much about whether you can be held accountable for something, or whether you need to justify your actions following an incident. So we talk about answerability and accountability and attributability. So do I have, as an agent, as a person, do I have to answer for the actions that I undertook as part of my job? Okay. There is legal responsibilities. We have duty of care. We have requirements on us from things like the Health and Safety at Work Act. Regulators also have legal duties. There's sort of soft law, which we call compliance, where you may not necessarily have to do things in a certain way, but you are expected to do so, and if you don't follow that sort of good practice and accepted practice, then you will maybe be held to account for what you've done. And perhaps a slightly more simple version at the end of all of this is causally responsible. So did an action lead to a particularly bad outcome? And why on earth does any of this matter? Well, so there are a number of problems we have, particularly with AI. So there's this thing we call the responsibility gap, where it's difficult to hold someone responsible for the harmful behaviour of AI. And this is the nature of the thing, and what Zoe was talking about. It is very hard for us to ensure and specify the safe behaviour of something like AI. We are working very imprecise operating domains. The environment is complex. The way the system works is not deterministic. If you think about particularly in healthcare, every patient is different. Some people think this might be a positive thing because we don't unfairly blame somebody for something going wrong. And this has been sort of controversial opinion on our project in some ways, but I think it is useful for us to learn from the mistakes that we have made. And in safety, we have this concept of a just safety culture. So you should be able to speak up about things that are perhaps unsafe, without fear of being blamed for something that went wrong. So we want people to speak up. We want them to feel empowered to do this. Another problem we have, and I won't labour on this too long if it's going to be discussed in the afternoon as well, but it's this concept of a liability sink, where we have a human operator in the loop with an AI system, because that AI system is uncertain. They are compensating essentially for that uncertainty. There may be lots of reasons why they may or may not intervene with an AI system, but they will largely get blamed for the consequences of something going wrong. One of the things we looked at in quite a lot of detail was there was a crash in the US with an autonomous vehicle run by an Uber company, and the technology in the autonomous car had a lot of problems with it, and essentially didn't work as well as it would, and failed to classify someone crossing the road. There was a safety driver in the car. They were not paying particular attention, so they weren't warned fast enough in advance that there was an object in the road. They didn't pay attention, and there was a crash. The only person who was held legally liable was the safety driver, despite all of the technology failings that were listed in the accident report. And this is, I think, a big problem, particularly in healthcare, where the clinician may be held to account for things that went wrong with the system. Another problem that we have discussed is this problem of many hands, where there are so many people involved in the building and deployment and development of a system that finding out who is responsible for something is really, really hard. And sometimes people get away with doing things, and sometimes people get the wrong blame for it. AI in particular, there's lots and lots of people involved. There's data scientists. We're using off-the-shelf tools. The system itself may adapt during deployment. But there is this inevitability of bugs. So what we need to be able to do is all of us in this chain try and reduce that problem. Okay, so having said all of that, we built this core concept which was about how we model responsibility. So we have an actor, a person, or an institution, so it might be an organisation, or an AI-based system. That is the actor. They are responsible for a particular occurrence. An occurrence is an outcome, a consequence, a task, a thing. And they have these different types of responsibility, whether it's moral responsibility or role responsibility. And this paper is just being accepted for a journal and should be available very soon for people to read. And we have a notation for this to try and sort of visualise the problem and make it a bit more practical. So one of the things we really want to be able to do is set up these models with all the different actors in so we can try and pin down in more detail who is responsible for things. So these are our actors, a computer, a person, factory. They're responsible for occurrences. Associated with those might be things, outputs from the work they're doing, which can be used by the different actors. And then we've got this type of responsibility. And then we want to be able to use these models to try and understand where things might have gone wrong. Either we're looking backwards following an accident, or we're trying to look forwards and predict where some of these things may happen, where the liability sink might be, where there's a many hands problem. So I'll just mention a few of these, but so people might they're shortfall, so they do some of what they're supposed to do, but maybe not all of it. People might be overloaded, they have too many things to do. There might be a conflict with two or more people are doing the same thing at the same time. So we've got these various different guide words, and safety engineers are very fond of guide word based analysis. It helps prompt us to think about what might go wrong. Okay. So here's just a sort of simple example. So we start off with what I would call a sort of neutral model of what the expectations are of things that people do. So our AI system in an autonomous car might be providing us with a prediction of possible collision. That's their task, the occurrence, and as a result of that they produce this warning, so that's the result. There's our safety driver who is supposed to intervene and prevent the collisions, and they may use this warning to help them decide when to do that. And let's say there was an accident. The AI system was causally responsible for a poor prediction which led to a late warning. Just to say, it is only causally responsible because it has no moral agency, because it is not a person. Therefore, it cannot be answerable for any of its actions. Further back in the chain, we might think about the people who built it and whether they are responsible for their actions. The safety driver will probably be the one who has to take the moral responsibility for this. Essentially, they become a liability sink, even though the other things in the chain perhaps went wrong. Okay. How am I doing for time, Ibrahim? Okay. So we've got an example here where we are looking at a type 2 diabetes comorbidity prediction system. So essentially what this does is provide a second opinion in a clinical consultation. This has been built for both hypertension and myocardial infarction at the moment. This is trained using the real patient data from Bradford teaching hospitals. There are some issues with that data. There is missing information, particularly for certain patients from higher deprivation backgrounds. And we use sort of data imputation to compensate for that. This is part of our due diligence. We're trying to improve the data set that we're using, but there is this sort of risk of bias becoming involved in the system because there might be more data from one group of patients compared to another group of patients. And what we wanted to do was build a model of roles and stakeholders over the full life cycle. I'll skip that one in the interest of time. So this is when the system's being used. Okay. So at the heart of all of this is a clinician. This is the one who is running the consultation. They have this duty of care towards the patient. The patient themselves is involved in the clinical decision making because they are discussing with the clinician how they're feeling, what their health symptoms are. We've got lots of sort of patient records. They may be being managed by lots of different people. This is where our many hands problem fits in. So there might be lots of different people managing the patient records and the patient data. The clinician wants to use information from the patient, from their patient records. And we've introduced this decision support system, which both predicts myocardial infarction. They can produce a summary of that. They may produce some explainable data to try and explain why have I particularly said that a patient is at high or low risk of a heart attack in the next 6 months, is essentially what the output is here. So this is all the different actors and their tasks, but this is the person at the heart of it. If we go back a stage further, so this is our, from the previous, the previous one, this is our AI system. This is how the system is being developed. And again, we've got a huge number of actors and responsibilities involved in this. So we've got the AI developer is more at the heart of this one, and it is their role to extract the data from the patient's database. Again, we've got a sort of many hands thing going on here because lots of people are managing the data. They're using tools. It's another, again, many hands. There's an issue. We might be quite often using sort of off-the-shelf software, which is not necessarily designed to be used in a safety-critical environment. There is the health regulator, who would be responsible for approving. There's a problem with AI good practice. See, there's nobody assigned to that because we don't really know what good AI software development looks like. There is NICE in here because they also have guidelines. So there's all these different bits of information, some of which may go wrong when we're building and assuring this AI. Okay. And so this is what happens when we try adding that analysis that I was talking about. So here we've got this issue of somebody maintaining the database, and there are so many different clinical practices from what I can tell, lots of different, everybody records things in slightly different ways, the data is not presented in a very consistent way. The AI developer has to extract the database information. There might be some problems with that. If they need to justify how well they did that, they may be asked to justify the actions that they took. And as a result of problems with the database, they may have even done their best. So they may be able to justify that I've done the best a job as I could of extracting that data. But those sorts of insufficiencies carry on into the final product, and as a result there might be some unpredictable outcomes. It might be very difficult for us to know, is it always going to work? The summary prediction might conflict with what the clinician is thinking of. Thank you, Ibrahim, I'm sorry. There's an ordering problem as well. So does the clinician look at the output from the AI first, so they make up their mind and then go to the AI, because that could influence their decision. And eventually it might lead to some problems with the treatment. Okay. So just a few sort of discussion points of this. I think I've summarised quite a few of them. The impacted party, the patient, actually also has a clear role and possible causal contribution in this. When we did this in detail, there were lots and lots of different chains of issues coming from all those different actors. And quite a lot of the mitigations ended up being, well, they could check for this, they could check for problems in the records, the clinician could do this, and that they risk being overloaded if they really did do all of that stuff. And at the moment, we haven't really thought about the size of contribution. So a smaller problem with one aspect of that causal chain versus a much larger contribution. Okay. So just to finish up, there are lots of responsibility issues. We have produced these models to try and help us provide some clarity on many of these different issues and try and identify mitigations. We think this could be used as part of a safety or assurance case. We can demonstrate due diligence on the part of the engineers. We can help argue about fairness and bias and things like that. This work probably needs a bit more validation from clinicians. And it might be useful to use this model after there's been an accident to see where we could pin down one of the causal contributions. So thank you very much for your attention.